All right, if you're a psychiatry resident, you know just how high stakes a crisis can be. So, in the next few minutes, we're going to build a really powerful, high yield mental model for managing exactly that. Let's jump right in. So, here's how we'll break it down. We're going to follow a pretty logical clinical workflow, starting with the basics of what a crisis even is, and then moving all the way through to on the ground strategies and long term planning. All right, first things first, let's get on the same page about what we actually mean by a crisis and how these situations tend to develop. Let's be super clear here. We're not just talking about someone having a bad day. A psychiatric emergency is when that stress response goes so far that it's actually endangering someone, either themselves or others. Their whole ability to function just breaks down, and that's our cue. That's when we have to step in immediately.
This is a really useful way to think about how a crisis escalates. You know, it's not an on-off switch, right? It starts with tension building up. Then, the person's usual coping skills, they just stop working. So they try to pull in other resources, maybe call a friend, but that fails too. And if we don't step in, they can land in phase 4, just major disorganization. Our job is to catch them way before they hit that point.
Okay, so when are you going to see these patients? Well, get ready for your evening shifts. The data is super clear on this. A whopping 70% of psychiatric crises show up between 8 p.m. and midnight. And you know who's usually with them? Family. They're often the ones bringing them in. Okay, so now that we know what a crisis looks like, let's talk about what to do when that patient is right in front of you. This is all about assessment, but with a huge emphasis on safety first. Look, before you even pull out your DSM or start thinking about a diagnosis, your first, second, and third priorities are all about safety. Number 1, is this person a threat to themselves or anyone else? Right away. Number 2, get the environment under control. That means a quiet room, and you absolutely have to know where the door is and make sure nothing is blocking it. Only then do you start pulling together the story from everyone, family, police, old records, you name it. This is a fantastic framework for organizing your thoughts. It's the 3 Ps. Think of it like this. What are the predisposing factors? You know, the chronic stuff that made them vulnerable. Then, what was the precipitating event? The thing that just happened, the straw that broke the camel's back. And finally, what's perpetuating this? What's keeping them stuck? Answering these 3 questions gives you a real roadmap for your intervention. All right, let's get into the nitty-gritty. What do you actually do in these high-stakes scenarios? We're talking actionable protocols here. Okay, so you've got 2 of the most common and most intense situations here, a suicidal patient and an agitated patient. And while they're both emergencies, your immediate game plan is totally different. With the suicidal patient, it's all about a deep dive into risk, and crucially, what happens after they leave the ER. With the agitated patient, it's about one thing, de-escalation. Right here, right now, for everyone's safety. When you're dealing with a suicidal patient, you have to be methodical. You're going to use tools like the Beck Suicide Intent Scale to really understand their intent. And for severe cases, especially with profound depression, don't forget that ECT is a powerful option. But honestly, one of the most important things you'll do happens right before discharge. You have to talk to the caretaker, and you have to get a clear yes that firearms are locked away and lethal meds are secured. This is a non-negotiable, life-saving step. Here's a great little clinical pearl for you, a quick bedside trick that can help you tell the difference between 2 kinds of drug toxicity. It's called the palm sign. If you suspect LSD, ask them to look at their palm. They might start describing colors, patterns, things that aren't there. But with PCP, which can make people paranoid and aggressive, they might just attack the hand. It's a simple, quick way to get a clue about what you're dealing with. So you've tried talking them down, and it's just not working. The situation is escalating. This is when you turn to rapid tranquilization. And this is your go-to high-yield IM protocol. Usually, it's a combination of an antipsychotic like haloperidol with a benzodiazepine like lorazepam. It works fast, and it's effective for getting control of a dangerous situation. Okay, let's talk about physical restraints. If it comes to this, there's one number you have to remember, 4. You need a minimum of 4 people. This is non-negotiable. It's not about overpowering the patient. It's about overwhelming safety. It's about having enough hands to control each limb and the head so that nobody, not the patient and not your staff, gets hurt. Okay, the fire is out. The immediate danger is contained. Now what? Well, your job completely shifts. You go from crisis manager to, a therapist. It's time to start digging into the problems that got them here in the first place. And I love this quote because it gets to the absolute core of what we do next. You have to be a therapeutic optimist. Think about it. Your patient is at their lowest point. They feel completely hopeless. You are literally the person who has to hold on to that hope for them. That belief you show them, that could be the very first spark of their recovery. So, how do you do that? Well, you don't have to reinvent the wheel. There are some great evidence-based tools right at your fingertips. You can use problem-solving therapy to help them break down a huge, scary problem into tiny, manageable steps. Or maybe it's an interpersonal issue. That's where something like IBT comes in. And I love joint crisis plans. You actually work with the patient when they're well to write down a plan for the next time a crisis starts to build. It's all about giving them back a sense of control. All right, for our last section, let's zoom out. We've been talking about what to do in the crisis, but what if we could stop the crisis from ever happening? Let's talk about systemic support. So when we talk about preventing crises, these two models are really the gold standard. You have crisis resolution teams. They do intensive home visits to keep people out of the hospital. Then you have assertive community treatment, or ACT teams. They have super small caseloads for the highest needy patients, and they provide 24/7 support. Both of these are all about bringing the care to the patient, wrapping them in support so they don't end up back in the ER. And really, that's the final question we should all be asking ourselves, isn't it? The goal isn't just to get really good at putting out fires. The ultimate goal, the real challenge, is to build a system that's so good at prevention that there are far fewer fires to put out in the first place. That's what we should be aiming for.